Welcome, everyone, to the ABIN monthly webinar. We are so glad you're here. It is 8 o'clock, and so we are going to go ahead and get started. I do want to remind you that if by staying on today's recording, or by staying on this morning's webinar, you are being recorded, and this webinar will be posted to the ABIN website along with slides. So that will be able to be accessed. I also want to send a quick reminder for a save the date. We sent out a save the date email yesterday, but we will be having our third annual ABIN conference at St. Vincent Center in Little Rock on April 8th from 8 to 4:30. This will be a free conference again this year, and we will be providing CEUs. So we would love you to join us if you're able. Mark your calendars because I know the spring gets busy and things fill up. We will open registration probably next week. We're tying up a couple of loose ends, but want you to know as soon as possible that conference will be happening. Okay, and now I am going to go ahead and introduce Dr. Muhammad. Dr. Muhammad is with us this morning. He was born in California and attended undergraduate school at the University of Khartoum. He attended medical school at the University of Colorado School of Medicine and is currently a family medicine resident running an outpatient MOUD clinic. And so this morning we're going to be talking about his work at that clinic and talking specifically about how to work with people who are injecting drugs and how to do that in a safe way. So, Dr. Muhammad, welcome. We're so glad you're joining us in Arkansas and can't wait to hear all the exciting work that you are doing.
Thank you so much for that great introduction. Um, so yeah, I'm a family medicine resident here in Fort Collins, and as part of our training, we usually run the MOUD clinic, which is the medication for opioid use disorder, every Wednesday. And honestly, it has been quite the experience. And so, what I'm going to try and do with this presentation really is kind of talk through um, IV drug use in general, kind of what the big concerns are and why we care about it, and then talk a little bit about treatment and sort of partnering with patients um, to kind of help make that, treatment plan more beneficial. And so without further ado, I'm going to try and share this screen here. Okay, hopefully that is showing up properly on
Yes,
there.
it is. I think it's in the presenter view because we also do see your side slides.
Hmm. That's
I think if you go to the top, there should be a um, start here.
so if I go to, if I share my screen, be able to do that. Let's see there.
There we go. And,
Okay.
and I just have to say, you caught me with talking about how to partner with patients. So I'm excited about that and can't wait to hear about this.
Thank you for that. So the topic of today's presentation is caring for patients who inject drugs. And so the agenda is really talking, kind of giving an overview of IV drug use, the prevalence, the complications that come with it, some of the common drugs that are used, harm reduction, and kind of an introduction to that concept. And then talking about some practical strategies to foster this compassionate and effective care for the patients. So from a definition perspective, IV drug use, also known as injection drug use, is administering substances via syringe or needle directly into the bloodstream. This method of drug administration is associated with honestly quite a bit of health concerns, social, economic um, complications. I like that went the other way around. So it's closely related to the prevalence of illicit drug use, whether that is pill form or any other form. Things like heroin, cocaine, amphetamine. It's very, very complex, to be honest, and we can approach this from multiple different angles: socio-political, financial, physical and mental health, crime and safety, autonomy and liberty, as well as on an international scale. And just by its very nature, um, illicit drug use, because it intersects so closely with the legal system, it becomes difficult sometimes to figure out the exact numbers and how big of a scale this is. And so when we're trying to look at how much drug use is being used, a lot of the time the numbers are really underrepresented. And so what we'll usually try and do is use hospitalizations or known complications as a proxy. And for the most part, it tends to give a good estimate. And so from a prevalence perspective, um, the United Nations Office on Drug and Crime estimated that about 11.3 million people worldwide inject drugs, with opioids being the most common. And again, like I said, this is likely an underestimation. Um, and then in 2018, the United States had approximately almost 3.7 million people who inject drugs, which is about 1.46% of the adult population, with the highest prevalence being among non-Hispanic white males aged 18 to 39. The report itself kind of goes by region. So it looks at Africa, the Americas, Asia, Europe, and kind of on a global scale. And when we're looking at these numbers, this graph is really the association between HIV, hepatitis C, and hepatitis V with in persons who inject drugs. And so looking at the absolute number, Asia kind of looks like it has the highest number, but then when we break it down by percentage of population, Europe actually has the highest percentage of population. And then over the last decade or so, there's been sort of a concerning increase in the amount of injection drug use. So the things we worry about with IV drug use in particular is that because it's such a rapid onset, it heightens the risk of overdose. And this is particularly concerning when we're talking about things like the new synthetic opioids like fentanyl, which honestly doesn't give people enough time to even be able to act by the time they realize they've overdosed. Additionally, um, there's a host of medical complications, including skin and soft tissue infections, endocarditis, which is by far and wide the most concerning and the most critical complication, as well as septic thrombophlebitis, which is infection of the blood vessels themselves. And then the people who inject drugs, just from a social perspective, they face quite a few psychosocial challenges, including mental health disorders, homelessness, social marginalization, and these factors contribute to a higher risk of suicide, as well as all-cause mortality. And then it makes it harder for them to seek care as well. And so, from a stigma perspective, people who inject drugs usually worry about interacting with the healthcare system. They fear that stigma, they fear that mistreatment, so they tend to seek medical treatment less at the cost of their own health and sometimes their own lives. And when we think about the how these things affect them, we're talking about people's lives kind of being ruined. They lose their homes, they become unemployed, they lose their families, they lose their kids, and so and occasionally they sometimes resort to criminal activities to finance the drug use itself. And again, this intersection between the legal system makes it kind of adds another layer of complication to the drug use. And so when we're looking at kind of the medical side effects, this is sort of a table that just looks at some of the infections that are common. Um, I um, I'm using this as sort of just a template. The details are not that important. But looking at kind of the left side there, um, the sort of the skin and soft tissue infections, the bone infections or osteoarticular infections, endocarditis, which, like I said, is kind of one of the more scary ones, to the point where they actually did a study to look at the mortality associated with endocarditis, and the age range for people who get endocarditis with IV drug use is the average age is about 27 or so. And the mortality associated with that is about 14%, which when you think about endocarditis in somebody who doesn't inject drugs, the age range is well above 60. And the comorbidities that come with that, and comparing those two things, you think of 14% is a pretty high number. And then obviously there's all the viral infections like HIV, hepatitis C, hepatitis B. And so all this is to say, there's quite a bit of comorbidity associated with IV drug use. Some of the common drugs we see, and so finding the exact numbers, again, we're back in that same position where it's very difficult to get actual exact numbers. A lot of the time, we actually get the information from the patients themselves. So if we're kind of behind the eight ball a little bit when it comes to new trends in different kinds of drugs or formulations, or if something is happening, because we will hear from our patients when something is happening. They'll come in and say, "Oh yeah, there's this new drug going around, and so and so that I know has used it, and they've had these side effects from it, or this is kind of what happened, and this is why it's become more popular." And so by far, the most common injected drug are opioids. Accounts for about 5.5 million of the 11 plus million folks who are injecting worldwide. Next is amphetamines, cocaine. So amphetamines and cocaine kind of fall into that category of what people would call uppers. And then people use prescription opioids and other kind of drugs, a little less so. All of this tends to vary significantly by region, by availability, by the local supply, by kind of local laws. And so there's a lot that goes into people's choices for what they're going to use. So what does all this mean? When we're talking about, IV drug use, all these medical complications, um, we worry about the burden. The the infections that happen, the cost that people pay in terms of their livelihoods, their loss of family members, their homes, their liberty sometimes. These are significant issues that we should be worried about. And then because there's so much intersection between public health, political, legal aspects, it becomes more complicated. Not to say that it's impossible to approach, but it's just a little bit harder. Enter harm reduction. So harm reduction is this approach. It's a set of practical strategies, and this is the definition that's used on the National Harm Reduction Coalition website. So it's a set of practical strategies and ideas aimed at reducing the negative consequences associated with drugs. It's also a movement for social justice built on belief in the respect for the rights of the people who use drugs. This was started by actually people who used to use drugs, and they were advocating for themselves that they deserve to be treated as human beings. They deserve the right to be given medical treatment. They deserve the right to be, um, interacted with in a respectful manner. And so it entails quite a few things. The definition itself is meant to be a little bit vague to allow for people to kind of extrapolate from that. So some of the strategies, like examples for things that can be done. So things like syringe service programs. These programs provide sterile needles to reduce the risks of infections that we talked about. It offers access to healthcare and social services. Usually these programs are sort of situated within a clinic that is meant for treatment for people who inject drugs. And it sort of creates this safe environment where people can go in and feel like they are not, this is not a hostile environment. they're able to go in, get these clean syringes, and protect themselves from all the infections that are associated with it. And there's been multiple studies looking at the use of these syringe programs and its effect on um, the amount of substance use, and there has been no increase in substance use when these programs are provided. On the contrary, when you give people clean needles, they tend to not get sick. They tend to do better. Um, One of the other things is talking about overdose prevention. And so this is kind of a broader conversation. So talking about naloxone um, as a medication that we provide to people to help treat an overdose, giving people fentanyl strips to test the drugs that they're using for the presence of fentanyl, which um, when you kind of take a step back and look at what fentanyl has been doing over the last few years, it's such a potent opioid that people use tiny amounts of it and sort of it to all different kinds of substances, including things like methamphetamine and cocaine. So um, not just for somebody who's like injecting heroin. So somebody who's using methamphetamine, for example, they can add a little bit of fentanyl to that and sort of try and temper the the effects of the methamphetamine. And because it's such a potent drug, um, people essentially causes respiratory depression, and they essentially die from this. And so the movement now is to try and have naloxone be present almost everywhere. And so even at our clinic, regular clinic or our MOUD clinic, we will often talk to patients about, do you have naloxone? Do the people in your circle have naloxone? If something were to happen, do you know how to use it? Is this something that's integrated in your drug use as a safety net? Um, and so we'll use these naloxone nasal sprays essentially and give them out to patients, which honestly has been pretty helpful. And they will come back and tell us, "Oh yeah, I had my friend um, who all of a sudden we were using together, and they sort of kind of went out of it, and they weren't breathing very well, and we had to use the naloxone, and they're very excited about it." And so this is one of the things that has been tremendously helpful. Um, Talking about safe injection education, so cleaning the injection sites, avoiding sharing equipment, and this goes back to the clean syringes program as well. But one of the things that can be very, very helpful here is kind of just taking a step back when you're talking to the patient and being like, "Hey, walk me through your injection practice. What do you do?" Um, and they'll kind of go through the steps, and you can start talking about, okay, so do you wash your hands? Do you create an environment that's a little bit safe where you're not rushed? Are you injecting in a room with a locked door? Are you on your own? Do you have somebody there, a buddy who can jump in and give you naloxone if it's needed? Do you reuse your needles? Do you share your needles? Are you making sure to rotate the veins that you're using? Are all of these are sort of conversations that once you've opened it up and had a talk about it, because at the end of the day, the goal is not really to completely stop somebody from using the drugs. I mean, ideally it is, but in an ideal world, but people will inject the drugs, and so having that conversation about how can we reduce the amount of harm that comes from this practice? How can I foster this relationship? How can I talk with you through these things and get to a point where we're doing the least amount of harm through these practices? And so having this conversation in an open manner, we're being like, okay, well, let's talk about it. Let's talk about the routes of use. So if you're somebody who is injecting, what other options, what other methods of ingestion have you tried? Have you tried oral? Have you tried, so there's a people will often sort of snort something. There's like a rectal use. So there's multiple ways to use drugs. And so talking through the different things, and a lot of people have gone through some of these options before and sort of landed on IV because it is sort of that, again, it goes back to that quick onset of action. And so having that conversation about it, I think, is going to be one of the bigger things to do. And then for when we're talking about some of these viral illnesses like hepatitis, HIV, hepatitis C, routine testing is incredibly helpful. And so when you think of somebody who has like, hepatitis C, for example, and they're sometimes they don't even think about, if I'm smoking, um, if we're smoking these drugs, you can still get hepatitis C. And I think I saw a question about a safer safer route. I think when you think about the safer routes, the injection is by far the probably the most dangerous. Oral can sometimes be one of the more safe ways because again, you're thinking about if there's anything in the drug, the stomach acid will usually neutralize most of it, and you'll have a lot less issues there. But again, we're trying to kind of just step it down. And so somebody will say, some people will just say, I just don't think the other routes are for me. In which case, um, no worries. Let's talk about how we can make the injection itself safer. So going back to the viruses, and so thinking about testing for these viruses and treating them, because if somebody is sharing needles and there is, an outbreak in HIV and hepatitis C, and these diseases are very common among people who inject drugs. Our Mount Clinic actually recently only started treating hepatitis C. So this is in the last 3 months or so, and so we've been routinely testing people for hepatitis C and HIV, but we have not been treating. And so now we added a new sort of component to the treatment program where while we're treating the opioid use, we will also treat hepatitis C. We will go through and do the routine testing. We'll get the viral levels. We'll do the liver testing for cirrhosis, and treat people through their clinic visits as well. And it has been, again, tremendously helpful. People are very, very appreciative of this, and you know, we're lucky to be part of this. So talking about MOUD, so medication for opioid use disorder, and there is this distinction to be made. And again, this is sort of a wording thing. There's MOUD and then there's MAT, so medication assisted treatment. MAT is more comprehensive, so it includes MOUD, but then there's also the behavioral health component to it. Our clinic is mostly MOUD, and so we provide the medication itself. We will talk with patients through all of this, but we're 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 more focused on um, the medication component of it. So um, the medications that we're using, the options include, and these are the FDA approved. So buprenorphine products in general, methadone as a medication, naltrexone can be used, and then obviously naloxone that we talked about is a sort of a stopgap for overdose that we provide to everybody. And so the benefits of this is that somebody who is maintaining buprenorphine or methadone treatment, the the likelihood that they will um, stay in the program and save themselves from the complications that come with illicit drug use, the number needed to treat for that, and um, you can correct me on this, I think is around 25 or so. So for every 25 people that we're treating, um, we will help somebody stay on these medications and effectively help save them from the complications of illicit drug use. And it's been studied extensively that their quality of life significantly improves for somebody who's on maintenance treatment. Um, the good thing about specifically buprenorphine is that it can be telemedicine based in rural communities, and so this significantly expands the access. And so when I think of our clinic, so our model really is split into two components. So there's the intake. When somebody comes in for the very first time, we will go through their history, talk through how did we get where we are today? How did you end up here? And why are you here today? What changed? So that intake visit really is about getting to know the person. And then this is usually in person. We'll do the blood draws. We'll check for the viral infections. We'll kind of see where they are in their journey for sobriety. Did you use this morning? Did you use 3 days ago? Are you currently in withdrawal? And then once we get them to the point where they're on maintenance therapy on buprenorphine, they don't have to come in anymore. So we do phone visits for this, and we prescribe the buprenorphine over the phone, and we'll just check in with them every week or every couple weeks, depending on how people are doing, and just send them the medication. And that has been because of the low barrier for this. People really like having these visits. They're excited about it. Um, so, and when we talk about buprenorphine specifically, it's a partial opioid agonist that's approved for opioid use disorder. We use the California Bridge from out of San Francisco as our sort of induction method. It's a really, really good resource for, how are we going to, in bring somebody into the clinic and get them started on buprenorphine, because there is a wrong way to do this. The patients will, they're very expressive about us not doing this right. And so we will talk them through kind of that withdrawal. So there's maybe I think two major ways that we can start buprenorphine for folks. One is sort of the macrodosing, where we essentially try and just flood their receptors with the buprenorphine. So we're doing high doses of buprenorphine multiple times a day, and that is in an attempt to sort of quickly get them on board. And for this, typically we'd want to wait for them to start to go into withdrawal, and then slowly kind of get them set up with this. The reason being, giving buprenorphine to somebody who still has opioids in their system is essentially putting them in precipitated withdrawal. And as anybody who's seen this happen before, it is not pleasant. It's not going to kill them, but it will for a lot of people sometimes deter them from coming back or saying, like, buprenorphine is a horrible medication. It didn't work for me because they were started on it too early, while they still had quite a bit of opioids in their system. And so that's one method. The other method is sort of the microdosing, and this is where the California Bridge truly shines. And so we actually just print out the patient information pamphlet that comes from them, and this is a very slow up titration of buprenorphine for somebody who's either still continuing to use opioids, or somebody who does not want to go through that precipitated withdrawal. Because even if we wait for them to have flush the opioids out of their system, they're still going to go into some precipitated withdrawal. So it is uncomfortable, and so the microdosing does work for some people. And so we will talk them through it. Where, for example, um, buprenorphine comes in multiple different formulations. And when you think about the one that we default to, which is Suboxone, so that is a buprenorphine naloxone combo. It comes with a little strip, and it's about 8 milligrams or so. And so that strip can be cut up at home with scissors. So people will cut it up into four pieces, being 2 little milligrams of it, and then start there. And then the next day they'll sort of do one in the morning, one in the afternoon, and then the next day they'll do four in the morning and two in the afternoon, and sort of slowly kind of up titrate themselves to get to the point where they are at a dose that is comfortable for them. And for some people, that dose might just be the two. For others, it's the four. For others, it's the eight. For others, it's eight twice a day, 3 times a day. So there's a wide range of where people feel comfortable. The other formulation for buprenorphine is the the one without naloxone in it. And so the naloxone component really is for it's kind of a safeguard. It doesn't really stop us from giving it to people, but when we think of if somebody's using the buprenorphine as prescribed, it's a buccal film. They just put it in their mouth. Some people say it tastes really, really bad, and which is why we will sometimes change them up. But if they are going to dissolve it and inject it, the naloxone component will kick in there, because it's not really going to be absorbed when they're putting it in their mouth. But if they're going to inject it, it's going to act as a safeguard. And so the other formulations would be something like Subutex, which is a pill form, or Subzolve, or there's a long-acting injectable for buprenorphine. And so there's multiple different options that we can talk with people about, how are they going to use buprenorphine and how it's going to help them. And then we'll follow them. We'll follow them for weeks, months, years, as long as it's needed for them to feel safe. And we'll call them, For most people who are stable, we'll call them once a month. And it's a lot of the time it's just hey, how you doing? How have things been going? And I've had patients where I'd call them and the first thing coming out of their mouth is like, "Oh, you'll never guess. I just caught a huge trout. I'm at the lake right now." The conversations tend to become more personal as time goes on and less focused on the buprenorphine and more focused on their well-being. And they'll share, after, I've started buprenorphine a few months ago, and I feel like now my relationship with my family is getting a lot better. These are the stories that really make us feel nice and warm and fuzzy inside. But that's not always the case. Now, this is the bane of my existence. Methadone is, it's a great medication. So methadone is a full agonist as opposed to buprenorphine. It is approved by the FDA for opioid use disorder, and it works fantastically for what it's meant to do. The issue is methadone is prescribed at approved methadone clinics. It is highly, highly regulated. This was something that was started 20, 30 years ago, back at a time where opioid use was very highly stigmatized. And so now the model for methadone has not really changed that much. And so the amount of methadone clinics in the country is under strict surveillance. It is monitored strictly by the government. For example, looking at Arkansas, there's about 7 clinics, and so these are the places where you can get um, methadone, and that's it. You technically could get methadone at the ED, for example, for somebody coming in. They can be discharged started on methadone in the ED and then sent out. But then if they don't live near one of these clinics or they're not close by, then it becomes very difficult because the system is designed in a way where to use methadone, you have to go to the clinic in person every single day and be given the medication, watched as you take it. So it's almost treated as like like a prison system where people will go in, and that's how the patients describe it. Is like, oh, this feels like prison. People standing in line, these long, long lines in the morning, and they go and they only get the one day of it. They'll take it, they'll drink it, they'll leave. It's pretty long acting, and so people feel pretty good about it, and then they have to come back again the next day. And then as they slowly build up trust over the months and the years, they start to be able to get these bottles to take home. But this takes a very, very long time. And so patients will say, I'm worried that if I move, for example, from my small city, like we have a methadone clinic here in Fort Collins. And so somebody will say, I've been in Fort Collins for the last, 10, 15 years. I've worked my way up in the methadone clinic to a point where now I'm getting the 1 month. Um, but then if I move somewhere, I'm gonna have to go back to the daily. And I cannot do this. I cannot work. I cannot function in life if I have to go to the methadone clinic and spend 2 hours standing in line every single day just to get some methadone to, stave off. And they're acutely aware of what could happen if they're not able to get their methadone because they're going to go into withdrawal. And for some people, that means going back to, heroin and fentanyl use. They're aware that this is something that could cost them their lives. So if something were to happen and they're not able to get their methadone, they worry. And so this is where the methadone becomes a little sort of logistically complicated. And so for us, when we're talking to the patients, we'll say, here are 2 main options for treatment. We're looking at buprenorphine, we're looking at methadone. If you feel that methadone is more helpful, again, because methadone is much more powerful than buprenorphine, especially in this day and age of synthetic fentanyl, buprenorphine sometimes just cannot keep up. And so I understand when somebody says, I tried buprenorphine, I can't do it, and it's not getting me there, and I need the methadone. In those cases, I would say go for it. Like you want to get them to a point where they're able to get the treatment they need. And so we just have to work with them, work with our local clinic, get in touch and be like, hey, what can we do to kind of help people get set up? Do you want us to start the induction in the hospital? Somebody comes in withdrawal. Do you want us to start the induction and then send them over? There's similar to buprenorphine, there's ways in which you can um, start somebody on methadone, with the big worry really with methadone being that it causes this exponential um, prolonged QT, which can then lead them into essentially cardiac arrest, and so they go into what is called torsades. So um, their electrical system in their heart just malfunctions, and so that's one of the scary things about methadone. And so worrying about that because it has such a long half-life. It's going to be in their system for days and days. And so people will start on methadone, they'll start a specific dose, get to a point where like actually this feels fine, and then the next day they'll take another dose, and the doses start to stack, and people are not aware of this, and then we get their EKG and are like, oh, this is concerning. Maybe we should not be doing this. And so um, forming that relationship with the local methadone clinic really, really is helpful, because finding one that's close by and that's able to provide the methadone that people need, I think, will save lives. And so when we're thinking about kind of in a broader sense, so again, going from that MOUD to the MAT model, um, outside of the medication, we're talking about integrating the primary care with mental health, with addiction services, and having everything be accessible and low threshold. Partnering with the local organizations, finding out, our local syringe programs, where are they located, and they often will offer more than just syringe exchanges. They'll have places where people can safely inject with a partner, somebody who's watching you and able to provide the naloxone if you need it. And then talking about, advocating for the funding, trying to get these syringe programs, trying to get the mobile units, trying to get the telemedicine infrastructure to help get these people the medications that they need when they need it, and to try and stave off relapses as much as possible. And so for kind of the general resources that I think are very, very helpful, the National Harm Reduction Coalition is a fantastic website. It has it has a registry of all the needle exchange programs, and our NCHN clinic is actually on the website, which I found very interesting. And the people that we interact with every day are on there as the contact folks. Harm Reduction International is also another website. Um, the SAMHSA website is the government website that maintains the list of the methadone clinics. It also has a whole lot of resources about treatment for, different treatment options for um, the different kinds of drugs that people are using. And then in Arkansas specifically, Um, the University of Arkansas has a matriarch program, something called Project Echo, where they will actually, let me think in this next um, slide. So this is the Medication Assisted Treatment Recovery Initiative for Arkansas Rural Communities. It's a partnership with the Psychiatric Research Institute um, and the Arkansas Department of Human Services, and they have addiction psychiatrists available free of charge for providers. You can call them, get some consultations, primary care physicians, general psychiatrists, APPs, physician assistants, anybody who is dealing with a patient who is injecting drugs, or somebody who is, or otherwise, and would like to talk through. You get to a point where somebody says, "Yes, you know what, I want to start buprenorphine," and you're just like, "I actually don't know what to do." Um, call and talk to them, be like, what can I do? How do we get these people started? What else should I be thinking about in these? So this is a fantastic resource, I think, for somebody who is just almost there and wants to do something but not quite sure of the details. Project Echo is the weekly conferences that they provide, and again, I'm mentioning these things. I'm assuming to some degree some of you are aware of these things, but I figured I'd just bring them to light because this is the kind of the local resources available in Arkansas. Um, so you know we're at this point now where we're talking about um, providing medication to folks, providing mental health support to folks, providing resources, and doing all these things. Um, Finding the local resources truly is the best thing that people can do to help themselves and their patients, to create that alliance that you want to form, this alliance with your patient. You want to be able to get to a point where they feel that they trust you enough to talk to you about these things, to talk to you about, oh yeah, I've had a relapse. This feels really, really bad, and what can I do to kind of help myself get out of this? And I have yet to meet a single patient who was excited about the fact that they're using drugs. And, they will all say, this is terrible. This is miserable. I wish I did not have to do this. And so, um, thinking about it in that context, that the patients themselves are aware of how, you know, difficult of a situation that they're in, makes it so that the blame of, oh, this is you doing this on purpose, this is you sort of, this is a moral failing on your part. That's the kind of language I think we want to stay away from. Um, and then I think I have another. Let's see. Let's chat real quick. How do we communicate to family members the importance of medication-assisted treatment as compared to just quitting drugs? I see some members who don't seem to understand how difficult quitting. That's a very, very good question. Let me just pull this and if that's okay. Um, so um, talking with families about this, it's essentially you want to think of this in a larger framework of somebody who is using these drugs has both a psychological and a physical reliance on them. And just stopping the medications all of a sudden is not going to be helpful because this is at the end of the day, this is a medical condition that we're treating. And so um, thinking of it as like somebody who is, if you talk about smoking, example of smoking cessation, the model we use for that is, motivational interviewing. We slowly talk people through it. We try, the quit line. We do the lozenges and the patches and all the things. And now, people are sometimes recommending vapes, which the studies are kind of interesting in that as well, or alcohol use. You think about alcohol use and how much the cost on the medical system just from alcohol use alone, the amount of people that we see in the hospital with the consequences of alcohol use, and telling somebody, oh, you should just stop, if you tried stopping the alcohol. So we know these strategies don't work, and so trying to get them on board to understand that this is a medical condition that we're treating, and that the tried and true methods of getting somebody through their substance use with medication assisted treatment will save their life. There is more than one, there's more than I think one major um, meta-analysis that's looked into the benefits of having somebody on MAT. And I think putting it in that perspective of like, if we do this, it will save their lives. We know this. And if we don't, we have seen people relapse and we know what that does to people. And, these are the numbers. This is how people are, you know, this is how we end up with people dying of a preventable condition. Any other questions?
I'm coming off camera just to help um, moderate and see, do we have any questions about this? Because this is a big topic. Um, and want to invite everyone to please, um, you know, come off camera and ask questions, put them in the chat, or just take yourself off mute and feel free to ask any questions that you might have about this topic because it's confusing. And I'm so grateful you talked about, you know, MAT coming under the umbrella of MOUD because this is a lot and it's a lot for us to try to um, dissect and understand. And you hear different acronyms and different words. Um, so as we're waiting for people to uh, come off camera and ask questions. I have a question. Actually, I have a couple of questions. One of my questions is, and I don't have a medical background, I have a behavioral health background, but when someone's struggling with opioid use, how is it decided whether they go to a clinic like yours for buprenorphine or a methadone clinic? What's that process? And why
That's a
would they go to one versus the other?
Yeah, no, that's a great question. So it's not so much a decision, it's more of a conversation about, this is what methadone can offer, which is somebody who is either continuing to use opioids and just wants something in their system to kind of temper that a little bit. Um, or somebody who, because again, when you think about like fentanyl, for example, fentanyl is so potent that we've seen people just say that buprenorphine just doesn't work for them. It just doesn't help. And so they will often go and seek out methadone because again, fentanyl is so short acting that they're injecting fentanyl multiple times a day, every couple hours or so. And then they'll get the methadone, which is a once a day medication. And they're like, actually, this is kind of better. And so that might be a reason why. The other thing is that when we're talking about methadone, like I said, it's difficult to maintain methadone as a as a treatment for many people. And so for those people, sometimes buprenorphine is a better alternative because it's just easier to get. You can get it at the pharmacy, you prescribe it, you get a month's worth, and then you take it as you need it. And so for those folks, I think buprenorphine is definitely a better option. And we have to talk with the patients through this idea that you might start buprenorphine and feel terrible. That doesn't mean it's not working. It just means we have to wait until the opioids are out of your system and you feel a little bit better. And if somebody is any opioid use, then buprenorphine is fantastic. And if they feel like that's not for them, then I think methadone might just be the alternative.
That's very helpful. Thank you. Looks like we have a question in the chat.
Over the pair. It's a good question. So the question is, discussing with patients lowering their MAT medication over time with the end goal of them ceasing use, or is there a collaboration with other parties comes in? I think the collaboration part is always going to be the case. If I can get the behavioral health team on board early on in the process, every time, because a lot of the initial reason why. So one of the reasons one of the things we talk about with patients is, how did we get here, right? And most of the time, the vast majority of our patients, I'd say, somebody had, either a back injury or something and was started on oxycodone years and years ago, and that's how they ended up with, on these medications. And so the goal really is to keep them safe. Ideally, we will talk with them about reducing their medication with if they can. I think that's great. And we'll ask them, what is your goal? Are you somebody who wants to be off of buprenorphine in the long run, or are you someone who feels like having some buprenorphine in your system helps you stay away from this? And that sometimes is the goal. The goal sometimes is to be on a low dose or to be on that dose to save them from the trouble of having to seek them elsewhere. And for some people, they will self titrate. They will call us and say, you know what, I've been on this dose now for 6 months. I think it's time for me to go down. And so we let them lead the conversation on, what's their goal? Is it off or is it less? Hopefully that answers the question.
That is a great point because one of the things that sometimes we hear, and we've been working in this space on several different opioid grants, providing um, information, education, promoting multiple pathways of recovery. And, one of the questions that I think sometimes happens is, are we substituting one drug for another? And um, how long should someone be on this medication before we start to titrate them down? So
Yeah, I think that's always an argument that comes up that I think is a valid one. But if you look at it from a harm reduction lens, um, substituting, you know, injection drugs or heroin or something that might have, you don't know what's in these drugs that people are getting off the street sometimes. Substituting that for a known and regulated medication that is studied, that is shown to save lives, that is shown to help people stay and function in their life and be able to work and participate in society. When you look at it from that lens, I think the argument becomes a lot less convoluted, and it's like, well, you have this here and you have this. What are we trying to where are we trying to go? So I see where the argument is coming from, but yeah.
that's wonderful. That's some of the things that we've heard in the community as we've been doing this work. So it's wonderful. You know, another thing that I heard you say, Dr. Mohammed, is really this is a medical disease. And so it's important for us to be aware this is a medical disease and there are medications to assist with treatment of the medical condition.
Yeah, we definitely treat it as a disease, and I think when we approach it from that lens and not as a, as somebody doing this to themselves or somebody who has failed as a human being because they can't stop doing this, then it becomes very, very different. It's if you think of it as like the way we would treat depression or anxiety and saying, somebody who has depression and is not able to function, and we say, you should just, pull up your bootstraps and get up and go do this stuff without treating you. That just makes things worse. And I think turning a blind eye to it, honestly just exacerbates the problem for the most part. And, the studies have also shown, for example, one of the things I'll talk with people about, because we treat buprenorphine, we treat with buprenorphine the opioid use, but then people use methamphetamine, they use cocaine, they use all kinds of other things. We use naltrexone for alcohol use. The I'll ask a lot of people who are, they've been using meth for a long time and say, what benefit are you getting from the methamphetamine? And they'll say like, sometimes I'll use it and I'll just have laser focus. And then I'll be like, have you ever actually been, tested for ADHD? And the rates of people with ADHD using meth is higher than the general population. And so when you think of it as this is another way where we can sort of tease out, something that's uh, you know, pushing people more towards using certain drugs, you can start to slowly, get them the treatment that they need. Because once somebody's on, a stimulant for their ADHD, they're a lot less likely to use methamphetamine to get the same um, that feeling of being able to function.
Absolutely. We've got a couple other questions coming in, so this is great. Um, all right. One of the questions we've got is, how do you encourage patients and families to deal with the stigma of seeking care?
Ooh, isn't that the question? This is really where we see a lot of the problems, and unfortunately, we are not free of blame as providers either. Um, the patients worry that the hospital for them is a hostile environment, that they will come in, that the providers will sort of focus on their substance use and not treat their other conditions that they're coming in for. They will opt to stay at home and, deal with some pretty terrifying infections sometimes just because they just don't feel like they're going to get taken care of in the hospital. And to give you kind of an idea of where their mindset looks like, um, our MOUT clinic is physically separate than our actual family medicine clinic. And I've had coworkers say, I've seen a patient in the mouth clinic and they will say, you guys are great. You treat us so much better than the folks over at the main clinic. I saw this doctor the other day who wasn't treating me very well. And then when they looked back at the chart, it was them. It was the same person treating the patient in the clinic. And so when they come into the clinic, their guard is up. They're worried about this. And so I think it's on us to give them that environment, to show them that, at the end of the day, I want to treat you for whatever medical condition you come in with through the door. For patients and families, I think the it's always going to be find find your people, find the providers that you think you're going to be able to work with, build a relationship with them, and you will be able to much more easily talk about your other medical conditions outside of because you are not defined by your drug use. That is something that is happening, but you are a person and you deserve the care that you should be getting. And so I don't know if I'm going to be able to answer this question fully, but I think just encouraging them to go and seek care no matter what, because they deserve it, they need it, and it's going to be on us at the end of the day to be able to do that.
Thank you. You're right. That's a very challenging question, and we really don't have the answer to that. We have another question in the chat. Can you talk about dialogue with law enforcement that might be helpful from a harm reduction perspective as a provider? knowing that some patients may not be able to access harm reduction strategies out of fear. Um, it seems like this could be helpful for patients.
It very much is. And this is a conversation that we have with patients all the time, is that we don't necessarily have to report every single thing. And that, for example, our some of our patients who are on buprenorphine will avoid coming in sometimes because they're worried their drug screen will show that they've used meth. And so that then becomes a conversation of we don't care. I don't care if your urine has meth in it. I will treat you the buprenorphine if you need it. Don't let that be a barrier. Don't let that be an issue. Working with law enforcement then becomes, it goes back to that forming the alliance and forming the having these conversations with your local resources about, what has been done in a local setting um, to sort of help keep these patients out of um, prisons and out of jail and out of because again, one of the things that happens is people will go into prison, they'll go into jail, they'll come out, their receptors have now reverted. They're not as used to the medication as they used to be, and then they'll overdose because they'll go back to the same doses they've been on. And this has been shown time and time again to be one of the bigger concerns with people being incarcerated. And if we're thinking of this as a medical condition and not as a um, moral failing, this is less of a legal issue and more of a medical issue. And so for us, for example, our local program, they will talk to law enforcement occasionally and be like, "Hey, this is one of our patients. This is happening. Where they're currently under treatment, and some of the law enforcement actually know some of the patients, and so they're less likely to pursue, um, you know, escalation, basically, and that actually keeps people in treatment longer, and it helps save them. But this is a think again, this is one of those questions that's sort of a broad conversation between organizations, between law enforcement, between hospitals and clinics and providers, and just having that open dialogue can be helpful. And it's difficult sometimes when the communities are smaller, when everybody knows everybody, and you're just like, oh yeah, this I know this person, and that makes it harder for them to seek care too.
Absolutely. So it sounds like open communication with law enforcement is essential. Um, and really getting out this message and I think talking more about this is really a medical condition and we are doing the best we can to treat it with medications and it takes time.
Agreed.
All right. Well, I think that was all of our questions and we're at the top of the hour. So I'm going to have one last call. If anybody has a question, wants to come off mute or put it in the chat.
I have a question.
Sure.
So, as someone that is new to the substance use treatment world, I would like to know, Dr. Muhammad, if you carry Narcan, first of all, if you carry it, when to know to use it. And my second question is, I feel like one of the things we do is we educate. So we are trying to get the word out how important this is, how it saves lives. Are there handouts that we can carry? Just like information. I just need lots of information and I want to know where to go to get that.
I love that question. Um, so to answer your Narcan question, yes, yes, I do. I think I either have it in the car sometimes or at home, and you can, you cannot, the risk of you harming somebody with Narcan is almost none. You can put them in withdrawal from it, but that's again, as opposed to them dying from overdose, not really that big of a discussion there. And so somebody who looks like they might have overdosed, they're not breathing very well because again, we're worried more about the breathing than anything else because they will stop breathing. The Narcan will help them come back and start to breathe again. And so if it looks like somebody might have overdosed, err on the side of giving them Narcan. And you can do it once, you can do it twice, however many times you need to until they get the to the hospital to the care that they need in an emergency department. Um, from a resource perspective, I think your local clinics your methadone clinics, your local buprenorphine clinics, your local syringe programs through the National Harm Reduction Coalition website has all of those resources on there and broken down in a very nice way. There's pamphlets, there's handouts, there's things that you can sort of work with with the local resources to kind of create that are tailored to your specific patient needs. And I would urge you to do that. I think that's a fantastic approach. Is to let's have all of the resources available and get it to the people who need it.
Thank you so much for answering that. Also, if you would put your email address in the chat, we've developed lots of different resources specifically to Arkansas on the HRSA opioid grant that we've been working on, and we'd be willing to share some of those if you think that might be helpful. Perfect, Dawn, or Dana, excuse me. Awesome. Okay. Well, it is 9 o'clock, and we cannot thank you enough for zooming in from Colorado and sharing what's happening in your MOUD clinic and all the cool, innovative things that are happening. It's wonderful to hear, and such a detailed presentation really made me think. And it's wonderful to know that there are lots of different treatment options. And thank you for your time and all the work you do. We can just tell you're passionate about this and are making such a huge difference in this community. So thank you for
I
your time.
I appreciate that. It is my pleasure.
Wonderful. Have a great week. Bye-bye.
All right, bye bye.